Hello, good day and good evening everyone, and welcome to IVF webinar by Egg Donation Friends. I'm Sophie and I will be your host today. I hope that you can all hear me, so please let me know in the chat section if everything is working fine before we will start. Okay. We are here today together with a great fertility expert, and this is Dr. Maria Arqué from Fertty International in Barcelona. And today's topic is IVF and miscarriages. Is PGT-A a solution? IVF case study. And the presentation will take around 25 minutes, and after that we will start the Q&A session. So if you have any questions, feel free to type those questions in the chat section, starting even from now. Before we will start the webinar, just a short reminder that this webinar is being recorded and you will be able to watch the recording on our website tomorrow. The link is available in the chat section as well, so feel free to use it. I think that this is all from me for now, and Dr. Arqué, are you ready?
Yes, I'm ready. Hi, Sophie. Hi for the thanks for the introduction. How are you?
I'm fine. I hope you are also good. And yeah, good luck and just go on.
Thank you. First of all, thank you all the audience for being here tonight. I know that tonight there's a very important football match going on, so probably there's a lot of people who would like to be doing something else. So I'm very grateful for everyone who's here today. As Sophie has said, the topic that I will speak about is IVF and miscarriages, if PGT-A is a solution, and I am going to present some case studies. What am I going to talk about? So basically, I will present the case studies, then I will speak a little bit about natural fertility, IVF and miscarriages. I will explain what is preimplantational genetic diagnosis, how is it done and what is analyzed, what do we want to achieve when we do the PGD, what patients would be candidates for PGD, what are the limitations of the technique, what do we know about egg donation and PGD, and what could be the conclusions about everything, okay? If you have any questions, as Sophie said, I will be more than pleased to address all the questions once we finish the presentation. So you can write all your questions and then we will go through everything, okay? So the first case that I wanted to present is a case from Michelle and Mark, who are a couple who have been trying to conceive for 2 years and that had 3 spontaneous pregnancies together. Unfortunately, all those three pregnancies that they had were miscarriages between 7 and 8 weeks of pregnancy. One of the pregnancies was a Down syndrome, the other one was a Turner syndrome, and another one that the products of conception were not analyzed. So Michelle was 43 years old at the time of the consultation and Mark was 40. And when they came, what we've done the full panel of tests that we do for recurrent pregnancy loss. Okay. For Michelle, all the tests came back normal. So she was screened for antiphospholipid syndrome and everything was completely fine. And for other thrombophilias, she had completely normal thyroid function, normal pelvic examination, normal karyotype, and ANA negative. Okay, and Mark also had all the full panel of tests required done and everything came back normal. In that case, what we concluded is that the most likely reason why they were having miscarriages was because of the advanced maternal age that I will explain in detail after, that there is a natural decline in egg quality and quantity with age, and that was probably the main reason why they were having the miscarriages, and therefore what we proposed was to do egg donation. We discussed also the possibility of doing PGT, and as this couple had already gone through a lot of miscarriages, and that gave them a lot of impact and on psychological stress and a lot of anxiety, they wanted to minimize as much as possible the risk of miscarriage, and therefore we've done a PGT-A with the egg donation cycle. What we ended up having with that cycle were 5 blastoses, and 4 of those blastoses were euploids, so were normal embryos. So what we did was to transfer the best good quality one, and we froze the other 3, and they had a positive pregnancy test, and they had a baby. And the other case that I wanted to explain is a different scenario. These were a couple who were younger. So Gina was 32 years old at the time of the consultation, and Peter was 36. They had been trying to conceive for 3 years as well, and they had and Gina had two miscarriages between 8 and 20 weeks of pregnancy as well with her previous partner. They didn't have any pregnancies together so far. Okay, and again, we've done all Gina full panel of tests required for recurrent pregnancy loss, and everything came back normal. And from Peter's side, what we've seen is that he had an alteration on the sperm, so he had what we call an oligosteinoteratosospermia, which means that the concentration, the motility, and the morphology of the sperm were lower than what's considered normal. The DNA fragmentation, that it's a genetic test that can be done on the sperm, was abnormal as well, and the sperm fish as well. That is another genetic test for sperm. So with those results, what we recommended them, as Gina had a good ovarian reserve and she was still young, we recommended them to do an IVF cycle with her own eggs and to do the PGT to select the embryos that were chromosomically normal. And that's what we've done, okay? Gina had a good response to the stimulation, and we ended up having 3 blastoses at the end of the cycle. And one of those blastoses was euploid, that it's the one that we've transferred, and she had a positive pregnancy test. Okay. So what happens with our natural fertility? So I think that probably most of the people who's listening already know that, because that's something that all the doctors who work in the reproductive field will explain very well to all patients, which is that there is a natural decline on the likelihood of conception with time. Okay. One of the main limitations that we have is that we are born with all the eggs that we have. We don't keep on producing new eggs during our whole life, and there is a natural decline with age. Okay, this decline is more important when we reach around the age of 35 years old. And also the other thing that happens with time is that the risk of miscarriage increases because of that decrease on the egg quality. So here in that table, you can see that as age increases, the likelihood of having Down syndrome or any other chromosomical abnormality of the embryos increases. So it is important to know, those are some facts that I find interesting to discuss or to explain, which are that 75% of conceptions will not be full-term pregnancies. That's within normal population, and not even patients who are struggling with infertility, but with general population. In natural cycles, the following embryo errors occur. So like in 31% of those cycles, there's an implantation failure. In 27% of the cycles, there's an early implantation failure, and only 42% of the embryos reach the 3rd week of pregnancy. Okay. And the other thing that it's important to know is that aneuploid embryos are a little bit more common in IVF. Okay, because of the culture media, because of manipulation of the gametes, because of changes in the temperature, oxygen, and other things. So in this table, there's some information about what is the likelihood of having embryos that are chromosomically normal depending on our age, okay, and also depending on the ovarian response. But what we can see is that when the eggs come from an egg donor, we could expect that around 61% of the embryos are going to come back normal, and when we are 35 or less than 35, around half of the embryos are going to be normal, euploid, and then there's an important decrease, and that decrease is even more important when we are over 40, when we see that between 41 and 42, there's only 17% of embryos that are going to be normal, and when we are over 42, less than 11%. In this table, what we can see is that there is that decline on the number of live births, so babies born out of cycles, in patients who are using their own eggs or in patients who are using the eggs from a egg donor. So when we see that in the patients that use their own eggs, that there is a natural decline with age because of that egg quality issue that we were explaining, and this likelihood decreases a lot around the age of after 35, but the decrease is very, very important after 42. And we see that these numbers maintain being pretty much the same or very similar, independently of age, if we're using the eggs from a dead donor. So now I would like to explain a little bit what's PGT, okay? So PGT is a technique that we use to see how that the chromosomes of the embryos are normal, okay? Depending on the kind of problem that we're facing, we can be speaking about different techniques, okay? The PGT-A is the technique that it's used to check the number of the numeric chromosomic abnormalities. When we're looking for the PGT-SR, it's to check if there are structural chromosome abnormalities on the embryos, like reciprocal translocations, reverse translocations, or inversions or deletions. And those two techniques are usually used on infertile or sterile population. And when it comes to genetic abnormalities or specific mutations of some genes that maybe one of the members of the couple is affected, and we want to make sure that we're not going to have embryos that are carriers or that are affected with that disease, we would be speaking about PGT-M, and this is a technique that can also be applied to fertile population but we want to avoid or prevent to have that disease. Okay, so how is that done? So the patient has to go through the IVF cycle, or either we're going to do a cycle with an egg donor, and we are going to generate the embryos in the lab. Once the embryos arrive at the stage of blastocyst, when the embryo has the 5 days of life, what's going to be done is a biopsy of the trophoectoderm. The trophoectoderm is the ring of cells around the blastocyst that is going to form the placenta, and some cells are taken out from there and are going to be analyzed, okay? Then those embryos are going to be frozen in the meantime that we wait for the results, and around 2 or 3 weeks after, we will have the result and we will know if those embryos are normal or not. If we have normal embryos, what's going to happen is that then we can carry on with an endometrial preparation and an embryo transfer. And if there are no embryos that are euploid or that are feasible for transfer, then we're going to have a consultation to discuss what are going to be the next steps to follow. So what we want to achieve with PGT, what we want to achieve is, obviously, we transfer embryos, right? And all the embryos might look very pretty or very nice at the blastocyst stage, but if we don't know the genetics of those embryos, it is very difficult, or to say almost impossible, to know what embryos are chromosomically normal and which ones are not. So what we're trying to avoid with PGT is, we want to avoid transferring embryos which are aneuploid, okay? And the other thing that we want to avoid is freezing embryos that are aneuploid. That way, what we want to achieve is that we are only transferring embryos that have normal number of chromosomes, and that we are only freezing embryos that have normal number of chromosomes. That way, what is the main objective of PGT? We can increase the pregnancy rate per transfer. We can decrease the miscarriage rate per transfer because we are already discarding all the embryos that are not chromosomically normal, and we want to increase the live birth rate per transfer. Okay? So what patients, what couples would be candidates for PGT? So patients who are infertile or sterile would be one of the populations, patients who have hereditary diseases, or patients who have chromosome reorganizations. So when it comes to infertile or sterile population, what patients would be eligible for that? So basically patients who have had recurrent miscarriages, that depending on the definition and depending on the country, that might be considered that it's after having 2 recurrent miscarriages, or in other countries that might be considered after 3 miscarriages. When maternal age is over 38, that's also a technique that might be considered as well, because of everything that I have just explained a few minutes ago. If there is a male factor as well, like low sperm quality, that might indicate that there might be an increase of the likelihood of having abnormal embryos. When there is male genetic factor as well, where there have been several IVF failures, so 2 or more IVF failures cycles without having pregnancies, or also when we had previous pregnancies with fetus that are carriers or that are affected with chromosome abnormalities. As I was explaining before, when maternal age advances, and especially after 38 years old, the egg quality declines and the likelihood of miscarriage and chromosomal abnormalities increases, and the pregnancy rates also decrease. And that's why if we look at the rate of aneuploid embryos, we see that it is almost 97% in population of patients who are between 43 and 45. And that's the reason why after 38 years old, that's one of the things that we might consider or recommend our patients to do. When there is male genetic factor, as we were saying, if there is very low sperm quality, or if we suspect that there might be a possible genetic male factor, we will indicate to do a karyotype. Okay, if the karyotype is altered, we are going to indicate to do a PGT, and if the karyotype is normal, we will probably do a sperm fish to check if there are any genetic abnormalities on the sperm. If that comes back altered, we're going to recommend to do a PGT or either to use a sperm bank. And if the sperm fish comes back normal, we can do a FIB-ICSI without needing to do the PGT, except if because of the female age or for any other indications, we might indicate it anyway. It is important to see that when there is low sperm quality, the likelihood that there is a fish on the sperm that is altered, it's around 45%. And the likelihood of having embryos that are not euploid, it's around 61%. As I explained in the case that I've discussed at the very beginning, the other candidates for PGT would be patients that have already had recurrent miscarriages, okay, having obviously previously discarded other causes of miscarriage, and that's the reason why we do a full panel of specific tests for patients who have recurrent miscarriages, okay, before indicating that, to make sure, to be certain that there are no other causes that might be contributing to the recurrent miscarriages. Around 60-80% of miscarriages are due chromosome abnormalities, so that's one of the main reasons why it is important also to take in consideration PGT as something that should be recommended or at least discussed with patients. And we know that there is a significant reduction in the rate of pregnancy loss after using PGT-A, especially if the pregnancy loss is of unknown origin in this kind of cases. So in case that we're speaking about hereditary disease, so patients who are carriers of specific hereditary diseases, that would be also an indication for doing PGT, okay? It is important to know that nearly 40% of cases attended in pediatric emergencies have genetic basis, that in Canada, between 2 and 5% of the children born have genetic diseases or congenital alterations, and that 50% are the cause of death in children in developing countries. The global prevalence of disease of monogenic diseases is around 3 per every 1,000 births, and around 10,000 human diseases are monogenic. So more than 1,300 monogenic diseases are of autosomal recessive or X-linked inheritance, and 1 or 2 of every 100 couples would have potential risk. Okay, so in this case, the patients who have already hereditary diseases would be patients who are fertile and that because of personal, economic, or family burden would like to do the treatment. Patients who feel guilt or anxiety, or who have misinformation about the chances of having a sick child, or who are misinformed about the possibilities of having a healthy child. Okay? And it is important to do a clinical diagnosis in all the cases that there is a clear cause, and also to do the according genetic study that it's necessary for that. Okay? And when we're speaking about what are the patients who are candidates for doing the PGT for hereditary disease, what diseases can be analyzed? So all the diseases that are causative by a gene can be analyzed. Previous genetic study is required from the person who is affected, and maybe it is required also to do an informativity study from all other members of the family who might be affected. And then we would have to do a cycle of IVF with PGT, okay? And can we test for all those diseases, as we were saying? From the technical perspective, yes. From the legislation perspective, no. There are some diseases that there might be the requirement of asking to the commission to see if it is possible to do that genetic test for that specific disease. At least that's how it works in Spain. And then patients who have chromosome reorganizations, like Robertsonian translocations or reciprocal translocations, would also be patients who would be good candidates for that, because only around 30% of patients, 30% of embryos of patients who have Robertsonian translocations are going to have embryos that are normal or that are balanced. And with patients who have reciprocal translocations, only 15% of the embryos are going to be normal or balanced. One of the other things that I thought that it was very important to discuss and to explain today is one of the limiting factors of the PGT, which is embryo mosaicism, that maybe some of you guys have heard about that already. Okay, embryo mosaicism is one of the results. Sometimes the results of the PGT might not be as conclusive as we would like. Okay, sometimes they are crystal clear, which means that we know that the embryo is healthy, that the embryo is euploid, okay, that has normal number of chromosomes, or that it's not carrier of any specific genetic mutation, and we can transfer the embryo. And then we also have the other crystal clear result, that it's when the embryo is not healthy and we cannot transfer it. Okay, but embryo mosaicism means that there's two lines of cells in the embryo, and that there is part of those cells that are carriers of some genetic alterations, and another part of cells that are not carriers of genetic alterations. Okay, these errors in the process of chromosomal segregation during the mitotic division of the embryo are the ones that give us the mosaic, and there are some different kinds of mitotic errors that lead to have that result. The likelihood of having embryo mosaicism does not increase with maternal age, and this is something that it's important to know. So what happens in the daily practice, and what do we know about what to do when we face that result? As I was saying, when we have euploid embryos, we know that they are healthy, we can transfer them. When we have aneuploid embryos, we know that those are not eligible for transfer. But what do we do with the mosaic embryos? So basically, our first choice would be to transfer the embryos that are 100% euploid. And with the embryos that are mosaics, that might have less than 40% of the cellular lines altered, we have to check with the geneticist, and we have to fully inform the couple that if we transfer that embryo, we have less likelihood of implantation of the embryo, and that there is higher risk of having a baby with chromosomical abnormalities, and therefore, most likely there would be an indication also for doing prenatal screening specific for that. So the fact that we are facing nowadays that result of the embryo mosaicism puts us in the situation where genetic reproductive counseling is required before and after the treatment when we are about to do a PGT, okay? Because it is very important that patients are fully informed about the procedure and the risks of the assisted reproductive technique and the PGT-A, or the PGT that we're going to do, options and risks of not choosing to do the technique, and obviously, those risks have to be explained in a very personalized way, depending on the specific situation of each couple. Okay, and about the PGT, it's important to explain the impact on the embryos, about the fact that we do the biopsy, the embryo culture, the vitrification, and the thawing, the limitations of the PGT technique used, about the misdiagnosis, about having sometimes to lead with inconclusive results, the mosaicism, and the recommendation of prenatal studies. the technical parameters of the genetic lab, the cutoff points for mosaic detection might be different in different labs, and more or less the broad directly related to false positive or negatives and implantation rates. And also the delivery time for results, because that means that whenever we're doing the PGT, we, as I was explaining before, we freeze the embryos at the stage of blastocyst, and then we have to wait until we have the result back. Prior to the IVF cycle with PGS, we have to inform well, as I was saying, about what is mosaicism, okay, and information regarding what to do with mosaic embryos. So first of all, that they have lower implantation rate, and they can give us a healthy born child, but also the risk is a little bit higher than we might have a baby with a chromosomical abnormality, that there is higher miscarriage rate, and there is higher risk of having a childbirth with chromosomical alteration, and that there's going to be required to do prenatal tests, that the percentage of mosaicism detected in the biopsy is not representative of the percentage existing in the rest of the embryo, and explain well the different types of mosaicism depending on altered chromosomes, monosomies, trisomies, and others. That there's the possibility of not having any euploid embryos to transfer at all if we do the cycle, and that all chromosomically altered or morphologically abnormal. And this is something that also has to be assessed specifically with the couple and explain them their personalized risk. And decide in cases that all the embryos are mosaic, whether to transfer them or not, and whether to freeze them or not. Decide if there are surplus mosaic embryos if we want to freeze them, as I've just said, and explain very well the legislation regarding IVF and PGT specific to each country, and all the alternatives that we have to PGT. And what about egg donation and PGT? Because that's something that that's a question that I get asked very often by a lot of patients. So it is important to know that donor egg pregnancies, although they are at lower risk of miscarriage due to chromosomal defects than pregnancies from patients with advanced maternal age, they may still carry a risk of adverse pregnancy outcomes and a risk of miscarriage. Most donors have between 20 to 60% of aneuploid embryos. That depends also on the lab or on the center where the treatment is done and other factors. And in general, we could assume that 45% of non-PGS embryos fail to implant, compared to 22% of embryos that have undergone PGS. This is a very interesting paper that was published recently that was checking the euploidy rates in donor egg cycles, and they saw that those euploidy rates differ a lot significantly in between clinics, okay? And one of the things that was said in that article was that it mainly depends on each center. So that mainly also depends on the techniques that are used in the lab, and it is very important to make sure that you're doing the treatment in a center that they have a state-of-the-art facility with very well-trained biologists who are very aware and who are very who are experts in all the manipulation and all the process of vitrifying the eggs, manipulating the eggs to make sure that the rate of aneuploidies on the egg donors is as minimum as possible. The mean expected rate of euploidy, so of normal eggs from egg donors, should be around 68%, okay? And in that article, we saw that it came between 40% to 82%, depending on how good were the centers. And then this is another very interesting study that was published in March 2017, that they were comparing the live birth rates in cycles of egg donation, depending on if those cycles were done with PGS or without PGS. And what was seen in here was that around 30% of embryos from egg donors were aneuploid, that in the patients who are using donor eggs, PGS was not associated with an improved pregnancy outcome compared to non-PGS cycles, and that the benefits of PGS on embryos from donor eggs may be limited and should be framed within each individual case. So to conclude, what I would like to say or to sum up is that chromosome abnormalities on the embryos are the main cause of miscarriage, which increase with maternal age. That the main objectives of PGT are to increase the pregnancy rate per transfer, to increase the live birth rate per transfer, and decrease the miscarriage rate per transfer. That PGT has risks and has limitations, that it is important to have genetic reproductive counseling and is recommended before and after the treatment with PGT, and that the benefits of PGT on embryos from donor eggs may be limited and that it should be framed within each individual case. Okay. That's the presentation so far. Thank you so much, everyone, for your time and attention. And now, if you have any questions, I will be more than pleased to answer them.
And thank you for explaining these complicated things to us. And of course, we have some questions, so we will go straight to the questions.
Perfect.
And the first one is long, but I will read that. We have had 2 miscarriages. Our is male factor infertility. DNA is very high. It was 41%, now 20%. Does PGS normal embryo mean it has selected a good sperm? Does it mean no DNA damage is present? We have had 4 cycles. First cycle 6 eggs, 1 fertilized, resulted in miscarriage. Then round 2, 13 fertilized, 1 miscarriage. Then we thought them and tested, so 2 normal. We have yet to transfer them. Cycle 2, 1 embryo inconclusive. Then the round 4, 10 eggs, and only 3 fertilized, starting to transfer the normal embryo. But what are its chances? I've had all miscarriages test and immunity and all okay.
So if I understand that question properly, Yvonne, you have just had the transfer of that last embryo, right? So if the embryo was transferred, first of all, let's go through everything that you said. The fact that now the DNA fragmentation is less, that's a very good information. So that means that the likelihood of having embryos that are chromosomically normal is better. The fact that the PGS is normal, that means that we've selected a good sperm, yes, because otherwise the embryo would not be euploid, the embryo could not be normal. Okay, and then regarding the chances, I don't have the information about your age, which is something that has to be taken in consideration as well. If the embryo that has been transferred is an embryo that is euploid, as you are saying, and it was a good quality blastocyst, which is some information that I don't have, the chances of having a pregnancy could be between 50-60%. And even more if you have done all the other tests that are required and indicated for recurrent miscarriages and they were normal. So if you are still waiting for the pregnancy test, I give you all my support and I hope that you have a positive pregnancy test and good news very soon.
We have the information about the age.
I'm 31, so okay. So age is not an issue there. So I think that we should stay positive.
Yes, and thank you for explaining this. And we will take the next question. Mm-hmm. Do you recommend PGD for egg donation?
So as I said at the end of the consultation, that really depends on each patient. Not all patients have gone through the same kind of process, and we all know that infertility can be an emotional roller coaster. I would especially indicate PGD for egg donation for all those patients who want to minimize as much as possible the risk of having any other miscarriages. As I was saying before, that minimizes the number of embryo transfers that we have to do because we are already selecting the best embryos and we know for sure that those embryos have a normal number of chromosomes, which means that increases the likelihood of pregnancy per every time that we do an embryo transfer. That diminishes the risk of miscarriage because, as I was saying before, the main reason for miscarriages are chromosomal abnormalities on the embryos, and that increases also the live birth rate per transfer. So I think that it really depends on the background of each patient, but it's something that that it can be considered, and yes, why not?
Thank you for your answer. And let's take a look for the next question. I'm interested to have egg donation with your clinic, but I have seen that you do not have any guarantee for blastocysts. If you do an egg donation, what is the number of blastocysts you get? And if there is no blastocyst, what do you do?
Hello. In fact, we warranty one blastocyst, so it is important to know what we warranty with our egg donation program is a minimum of 8 mature eggs from the donor for you. Okay, and then we have to assess well that there is no male factor, so that has to be studied. But if we see that there is no male factor and the sperm quality is completely normal, we guarantee that you will have at least one good quality blastocyst for transfer. Okay, the average number of blastocysts that we get out of a cycle is around 2 or 3. So in most of the cycles, what we get is one very good quality blastocyst for transfer and 1 or 2 for freeze.
And thank you a lot. The next question is the recipient who has to decide if she will be going in for PGD, or it's the center that decides?
Yeah, I think that it really depends on each case. There are cases in which there is a medical indication for doing the PGD, right? So in the cases that there is a medical indication, obviously the medical team has to be very proactive and to take an important role there to assess it and to recommend it, especially if we're speaking about patients who have hereditary diseases, or especially if the risk of having chromosomical abnormalities is very high. In other cases in which we are saying like, look, we're doing the PGT, or we can offer the PGT as an option because you have already gone through several miscarriages and you don't want to go through that stress again, or because you want to minimize the time to pregnancy, you want to increase the chances of pregnancy every time that you do a transfer, then obviously the patient should decide. I mean, always when it comes to medical decisions, paternalistic medicine, it's already out of the daily the daily practice. I mean, it should be a shared decision in between the patients and the doctor. But I think that the doctors will have a very important duty here to give as much objective information to patients to make informed decisions. So here, what I would say is that if there is a medical indication for PGD, obviously the doctor has to indicate it, but that's an option that has to be always discussed.
Thank you for the answer and the question, of course. And let's have a look for the next one. What kind of alternatives to PGD do you mean?
Okay, when we speak about alternatives to PGD, the alternative is not testing the embryos, depending on the situation, and take all the risks. Or in the case that we are doing the PGD because there is high risk of chromosomical abnormalities, let's say because of maternal age, the alternative would be to use the eggs from an egg donor. Or if we're speaking about using the indication for the PGD is because there's a male factor in fertility that increases the risk of having embryos that are abnormal. In that case, the other alternative would be to use the sperm of a sperm donor or a bank.
Thank you again. And let's check the next question. You mentioned indications for PGT-A. Is abnormal sperm DNA fragmentation an indication to the PGT-A, as it wasn't on the list?
Is abnormal sperm DNA fragmentation an indication to the PGT-A, as it wasn't on the list? So normally, when we see that the DNA fragmentation is altered, what we would do is speak with a couple and consider doing the PGT-A, absolutely. And the other thing that we use in our clinic is a device that it's called Fertile. And the Fertile is a device that will help us to select better the embryos that have less percentage of fragmented DNA on the sperm. That obviously, I mean, it has to be assessed with all the medical history of the specific couple, because there are some other factors that have to be taken in consideration. But in a couple that already had 2 miscarriages and that has a DNA, that we do the DNA fragmentation for him and it comes back very altered, we might assume that most likely this is the reason why, and if all the other tests come back normal, that this might be one of the main factors contributing to that. So then we would obviously be indicating to use the fertile, and also to do the PGT-A to reduce the risk of miscarriage. Previously, we will give all the indications to about all the things that can be done to try to diminish as much as possible the DNA fragmentation.
Yes, and thank you for all the information you gave us in this answer. And check the next one. Is it possible to transfer the embryo in natural cycle for the patient in egg donation treatment?
The answer is yes, but when we do, if we're doing natural cycle, it is important to take in consideration here that normally with egg donation, it has to be taken in account if the cycle that you're doing with the donor has to be synchronized or not, depending on if the eggs that are being used from the donor are fresh or frozen. So my answer here is, if you're doing a completely if you need to synchronize the cycle with the cycle of the donor, because it's a cycle that it's with fresh eggs, if you don't even take the oral contraceptive pill to synchronize your period with the period of the donor, that cannot be done. Okay, because we have to make sure that the timing of when the eggs are collected matches with the endometrial preparation. If you take the oral contraceptive pill before and then you have a cycle, it can be a natural one. If you're using frozen eggs from the donor, it can be done with a natural cycle without any kind of problem. I mean, normally in most of the clinics, we tend to prefer to do medicated cycles for patients who are about to do egg donation because of several reasons. One of the reasons is because it's easier to synchronize the cycles. Second reason is because the likelihood of cancellation of the cycle is much less, because sometimes when we do a natural cycle, we might have an ovulation that it's a little bit before than what we expected, or later. Sometimes you know that it can be tricky to spot ovulation, and it is a little bit more sensitive to that, you know, that from the time that you ovulate and when your body starts to produce progesterone, we have to do, after you had the LH peak, we have to do the transfer around 7 days after. And sometimes it might be a little bit more tricky to exactly see and spot the ovulation. But technically it can be done for sure, especially if you're using the eggs from a frozen donor.
Thank you for explaining this as well. The next question for you is, how long usually do we have to wait for a result of PGT testing of embryos? A few weeks, or is it possible to have it done very quickly?
Okay, so usually for PGT testing of the embryos, the result, it takes between 2 or 3 weeks to have the result back. There is also the possibility of doing something that it's called, when we speak about PGT-A, there is also the possibility of doing the PGT-A Express, but I would not recommend to do the PGT-A Express, because the PGT-A Express, we have to do the biopsy of the embryos on day 5. And as you know very well, because most of you have already gone through several treatments, even though the embryos are supposed to reach the stage of blastocyst on day 5, sometimes there are embryos that are a little bit slower in the development. And the embryos have to be at the perfect stage of blastocyst, of a full developed blastocyst, to do the biopsy in the best moment, and to make sure that the technique is not going to do any harm to the embryo, that we are going to have all the information that we need and everything. So even though there is that possibility of doing the PGT Express and have the results within 24, 48 hours, my recommendation would be to do the normal PGT, to allow the biologist to have all the time that they need to do the biopsy of the embryos on the day that it's better and in the hour that it's better, and then have the results after 2 or 3 weeks.
Thank you for your answer again. And We will take a look for the next question. Do immune issues affect the implantation?
Do immune issues affect implantation? Look, I can say that most likely yes. When it comes to immunology, we are still in a field that reproductive endocrinologists, all the doctors that we work in that field, we all know and we are all certain that for sure immunology plays an important role, but we're still trying to understand exactly what is the role there. When we speak about immune issues, that's a very general question. What I can say is that for sure, patients who have immune issues normally have lower implantation rates, and that depending on what specific immune issues we're speaking about, that can definitely play a role, and that might decrease the chances of conception.
Thank you for the answer and the question, of course. And we will take the next question. My husband has low sperm count. We have had 2 rounds of IVF. I have had 2
Chemical pregnancy.
pregnancies and 1 missed miscarriage at 7 weeks. I have a frozen embryo left, but I do not want to transfer as I'm afraid of another miscarriage. I am 36 and my husband is 34. My AMH is very good, however, my husband has high DNA fragmentation. Do you think PGT-A would be good for us or egg donation?
Well, in that case, and Marie, as you are still 36, for what you're explaining, you have very good AMH, and I'm assuming that most likely the egg quality will still be very good because even though you're 36 and we said that there is that decline starts when we reach the age of 35, you're still young enough. And what you said is that you had 2 rounds of IVF, but my understanding for your response is that you have not done any round of IVF with PGT-A. If your husband has very high DNA fragmentation, I would recommend him to go under antioxidants, to avoid smoking, to avoid drinking, to have very healthy diet, to exercise a little bit, to avoid saunas or anything that any environments that are very hot, and because all those things might increase the sperm quality, even though there is no certainty. Okay, and then I would definitely do the cycle using the fertile to select the sperm that are less fragmented, and I would definitely do a PGT-A to diminish as much as possible the risk that you have a miscarriage before going to egg donation, because I think that you are young enough to have still, and if you have a good ovarian reserve, there are still good chances of having a successful outcome without having to do egg donation.
Thank you. We will check the next question. Can I have a fresh transfer with PGD?
Yes, as I was explaining before, there is the possibility of doing the PGT-A Express, which means that then we would have a fresh transfer. But as I was saying, sometimes one of the limitations that the biologists who are working in the lab might face when we are doing that is that if there are some embryos that are a little bit slower in the development, they might not be in their best time for doing the biopsy. And if that is the case, that might, from the technical perspective, that might be a little bit more difficult, and sometimes we might have it might be more tricky to have definitive results that are completely conclusive if we find these technical difficulties, but it is possible, yes.
Thank you for the answer, and take a look for the next question. Is it true that sometimes some embryos which are perfect morphologically turn out to be chromosomically abnormal, and some weak morphologically embryos turn out to be healthy?
Yes, so it is true that sometimes embryos that are perfect morphologically turn out to be chromosomically abnormal, and other embryos, I mean, if the morphology of the embryo already looks very bad, most likely it's going to be an abnormal embryo from the chromosomical perspective. But it happens sometimes that an embryo that doesn't look especially very good, or that from the morphological perspective you could say that it's average, then it comes back completely normal, and then you transfer that embryo and you have a pregnancy and a healthy baby. So yeah.
Thank you. And let's check the next one. My NK cells test was done via blood test. Is this valid, or is a biopsy better?
Well, when it comes to NK cells, obviously, when it comes to NK cells and you are about to test them, when you have the result in your blood, it's true that the blood is not the environment in which the embryo is going to be. The embryo is going to be inside the uterus. So when it comes to that, to make a full assessment, what I would suggest is that it's better to also have the information about what are the NK cells and what is the result that we see in an endometrial biopsy, to see if the alterations that were found in the blood are also found in the uterus, in the endometrium.
Thank you. And we will take a look for the next question. As the miscarriages rate is increasing as per woman age, is there a cutoff point where at certain age there's an indication for using donor eggs instead of own eggs? Is it age and or individual medical situation depend, or there are strict recommendations about the age of woman for donor egg option?
That's a very good question and very interesting one. There is not a clear cutoff point because that really depends on each patient. It is not, let's say, for example, let's say that I have a patient who is already 40, okay, and she has extremely low ovarian reserve. Probably in a patient who is already 40 and has extremely low ovarian reserve, I would recommend egg donation as the first treatment option because I know that it's the option that would give her best chances of having a positive outcome, to have a child out of the cycle. But I completely understand that one of the things that I always tell to my patients, and I think that it's super important, is that at the end of the day, when you are about to do a treatment, you have to be convinced about the treatment that you're doing. And normally, egg donation is the plan B for everyone because all of us, we dream about having kids with our own eggs. That's the thing. So even though the chances are slim, if someone that still has possibilities, and I explain very clearly what are the possibilities, and they have never tried to do IVF with their own eggs, want to give it a try, they want to give it an attempt, and there is no medical contraindication for doing that, this is something that we can do. Even though my recommendation would be to do egg donation, and I will explain them that that the chances of success would be much higher with egg donation. Okay, and then you might see another patient who is 42 and that she has an extremely good ovarian reserve and that she already had, I don't know, one kid when she was younger with her first husband, and now she wants to attempt again. So yeah, maybe she's going to have just one good egg out of every 20. But if we get 20 eggs because she has very good ovarian reserve, she still has good chances. So unfortunately, there's not something that works for everyone. There's not a general scheme or a cutoff point for that. It has to be very individualized. But mostly age and ovarian reserve would be the most important factors that determine the prognosis and the decision making and what we would be recommending. What I would say as well is that I would not recommend any patient who is over 45 to go ahead with a cycle with her own eggs, because after 45, for sure, chances of having babies with your own eggs are extremely low. So
thank you a lot for explaining this as well and all the information. And let's have a look for the next question. Do you recommend ERA test before egg donation?
Okay, so ERA test is the endometrial receptivity test, which is a test that it can be very helpful, but I would not recommend to do the ERA test for all patients. So basically, ERA test is a test that would be recommended for all those patients who have had implantation failure or who have had several embryos transferred that are good quality embryos, and even more if possible, if we have the information that those embryos were euploid, so chromosomically normal, and they did not implant, then I would do the ERA test. okay? And all the times that we have a lining that looks normal, because it would be a completely different story if we are already speaking about patients who already have very thin lining. If you want to do the test anyway, to be completely on the safe side and make sure that you are in the correct window of implantation before going for the egg donation, because it's the last attempt of treatment that you're going to do, it's fine. But from the medical perspective, unless you are on any of the situations that I've explained, there would be no indication for doing it. And moreover, from out of every 100 patients who do the ERA test, 70 of them will have an ERA test that comes back completely normal. There it's only 30% or even less of patients that will have an abnormal ERA test. That might be the reason why the embryos are not implanting.
Thank you a lot for diving into the question. And we will have the next one. If 60-80% of miscarriages are because of aneuploidies, chromosomes abnormalities, as I saw on one of the slides, what about 20-40 of patients outside this group? Is there anything else, I mean, different path they should go? Or maybe it's worth to ask if it's really possible to distinguish these two groups before making the decision about PGT-A?
Well, the other, that's a very good question as well. The other causes of miscarriage usually are because the female might have some uterine malformations or some other factors in the uterus, like polyps, like fibroids, that might interfere there, or if the patient is affected by a thrombophilia, like a antiphospholipid syndrome or any other thrombophilias. So those are tests that usually in patients who have had 2 miscarriages or more are always done before we indicate the PGT-A, because if we already spot that the causes that the main cause of the miscarriages is not because of chromosome abnormalities, is because of one of those things, that's going to be diagnosed before and treated. So if there is a uterine malformation and there is a polyp or a fibroid, that we can do a hysteroscopy or a surgery to repair it. And in the case of patients who are affected with thrombophilias, what we can do is treat them accordingly with aspirin and heparin as a prophylaxis for having any of those problems.
Thank you again for the answer. If you have any more questions, please type them in because we are having one more question for now. And let's take a look for this one. Do you find a donor who look like the patient?
Yes. So under Spanish legislation, it is very important to know that egg donation is anonymous. So that means that you cannot know the identity of the egg donor, and neither the donor can know your identity. But also, Spanish legislation says that that the patient is not supposed to participate actively in the selection process of the donor, but the medical team, we have the obligation to look for a donor that looks as much as you as possible from the phenotype perspective. That means similar color of eyes, color of skin, color of hair, everything. Even more, apart from using pictures from the donors and assessing all the characteristics, we also use an artificial intelligence device that it's called PhenoMatch, that analyzes more than 100 points of the face to try to match the donor in the best way possible with you.
Yes, and thank you a lot for the answer. Someone is typing a question, I think, so we will take a second and wait for the question. And it comes up. Could you describe what kind of information patients get on the PGT-A test results as per embryo? I mean, what we can see on the results, and who make the final decision which embryos to transfer?
Okay. Yes. So the information that you will see in a PGT-A test result, what you will see is the embryos that are euploid, which means that are normal, the embryos that are not normal, and if there are any embryos that are mosaic, you will have a little bit detailed information about what kind of mosaicism. If we have embryos that are euploid and embryos that are not normal, the decision here is very clear. So the euploid embryos can be transferred. The embryos that are not normal cannot be transferred. And the embryos that are mosaic, that really depends on the kind of mosaic and the percentage of mosaicism. There are some guidelines with some indications about what to do depending on the kind of mosaicism that we find. And there would be a genetic counseling consultation to explain that with the couple and make the recommendations.
Thank you for this answer as well. And we will now have the next question. Do you check the level of estrogen and progesterone one day before transfer? Mine were checked before transfer and the progesterone was 8.3. The transfer was unsuccessful. I was told in another clinic that the level of progesterone was too low, that it should be over 10. Is that true?
So, Beata, yes. So we check the level of estrogen and the progesterone before the transfer. It's one of the protocols that we started to implement because there's more and more data showing that for patients who are going to do a frozen embryo transfer or patients who are going to do a cycle with eggs from an egg donor, that the progesterone levels are very important. So what we do is that before the patient is going to start the progesterone, we check that the progesterone is negative because that's what we want to do, just to make sure that there's no displacement of the window of implantation. And then the day before the transfer, we're going to do the progesterone again. If the progesterone is less than 10, the patient will not only continue using the vaginal progesterone, but also will start using the injections of progesterone as well. The fact that I am so sorry that last transfer did not work for you, Beata, but I don't know if that embryo was analyzed and we knew if that was chromosomically normal or not. So it cannot be certain for sure if the cause was because of the progesterone, because the progesterone is a little bit low, but it's pretty close to 10. So it is hard to know what was the cause in that case, but the answer is yes, that we check it and we aim to have a result that it's over 10, or otherwise we supplement with more progesterone that it's given with subcutaneous injections.
Thank you for the answer. And the next question for you is, can a biopsy for PGT be done on day 3 or day 5? What day is best and why?
Okay, can a biopsy for PGT be done on day 3 or day 5? Yes, the biopsy can be done on both days. The thing is that when the embryos are at the stage of day 3, they have just between 6 and 8 cells, and we have to take just one cell. The embryo is in a less developed stage, so the risk of damage of the embryo is a little bit higher, and we get less information because we would be analyzing just one cell. When we analyze the embryo on day 5, the embryo is more developed, which means that the embryo has already between 100 150 cells. We're going to take few cells, okay, but as the embryo has much more cells, the risk of damage is less, and then we will assess the genetics, the chromosomes of several cells, which gives us more information. So just to conclude, it is better to do to have more reliable information, it is better to do the biopsy on day 5.
Thank you for the conclusion. And then the next question for you, is there any information about embryo sex on the test result?
So even though we could know the information about the sex of the embryo when we do the PGT, in Spain, gender selection is not legal, is illegal. So this does not appear in the results, and we cannot choose the embryos to transfer depending on the sex.
Thank you for telling us this as well. And the next question, can you please give an outline of the process for IVF with PGT-A from start to finish? I would be traveling to your clinic from Ireland. I am trying to calculate how much traveling I would need to do. Thanks.
Okay. Basically, if you start the IVF process with us, we would have an initial consultation that can be an online consultation that it's free of charge. We can do the consultation through WhatsApp call. We can do it through Skype, whatever suits you better. I'm going to check your specific case. I am going to see what are the tests that you need. And then once you want to start the treatment, you can start the stimulation in Ireland and you can do the scans with your gynecologist in Ireland. You know that usually when we are about to do an IVF cycle, you start the medication on the third day of the period, more or less. Then you continue, okay, with the medication, and then you will need an average of 3 scans, more or less, until you're ready for the egg collection. You will have to come over the day before the egg collection at least, or maybe to do the last scan here, remain here on the day of the egg collection. If you're traveling with your partner will have to come with you to produce a fresh sperm sample. And then what we're going to do is we're going to generate the embryos, let them grow in the lab, and let them develop until they reach the blastocyst stage. The day after your egg collection, you can travel back to Ireland. Okay, and we will keep you informed. We will call you on day 1 to inform you about the fertilization, then on day 3 to explain you what's the quality of the embryos, and on day 5 and 6 to inform you about how many embryos could we do the biopsy on. Okay, and then around 2 or 3 weeks after, we will have the results of the embryos, if they are chromosomically normal or not. We will have another Skype or consultation where I will explain you what are the results, and hopefully we will have embryos that are going to be euploid and are going to be suitable for transfer. And then what we're going to do is schedule the dates for preparing you for the embryo transfer, which means that you can, with the next period, you will start the endometrial preparation. You will undergo the endometrial preparation for 10 or 12 days. Around 10 or 12 days after, you will have to do a scan, okay? Then once we see that the endometrium is prepared, we're going to check, we're going to tell you when you have to start the progesterone, we're going to plan the transfer, and then we're going to thaw the embryo accordingly.
Thank you for leading us step by step through the process. And the next question we will have is, do you have also embryo adoption treatment?
Unfortunately, we don't have embryo adoption because we don't have embryos to adopt in the bank at the moment. But for patients that would be thinking about that kind of process, what we can offer is what we call a mini egg donation, in which obviously it's going to be more it's going to be cheaper for you, and what we would be guaranteeing you is a minimum of 4 mature eggs from the donor for you. And depending on your specific situation, if you need a sperm bank, we're going to look for a donor sperm, or either we can do that treatment with your male partner if you have a male partner.
Thank you for answering this as well. And let's take a look for the next question. Dr. Maria, I had a consultation with you by Skype a few months ago, but I have some questions and I would like to ask you, is it possible to have a short Skype meeting?
Absolutely, yes. So what I would suggest is that you contact the team from Fertty International. So the email is Fertty at ferttyinternational.com. You can send an email there and tell my colleagues, the patient assistants, that you would like to have another Skype meeting, and we are going to go in detail through everything. Absolutely, I'll be happy to do that.
And thank you for the answer as well. I also put into the chat section the email of Egg Donation Friends. If you have any questions or need for Skype consultation, we will forward everything to Fertty International and Dr. Maria. So feel free also to throw us an email and contact us. So do what is needed, and we can have next question for you as well. I am very interested in mini egg donation. Can I have a Skype meeting with you? Which is also the answer.
Absolutely, absolutely, yes. As I am saying, you can contact directly to our patient assistants to that email address that I said, fertty@ferttyinternational.com, and I will be pleased and happy to have a consultation.
Great. And for now, we don't have any more question, but someone is typing, so we will wait for the question. Okay. Here you are. Thank you. For now, we don't
You're
have
welcome.
any more
Thanks you.
questions.
Thank
So
you for
if you
listening so far, because we've been here for a long time already. So thank you for listening.
If any questions arise, just please type them in, and this will be the final question. If not, we will be slowly finishing. So anybody who would like to have one more question, the time is now. If not, we will be saying bye-bye slowly. So thank you for the presentation and all the explanations and answering the questions, and for your time also.
Thank you, Sophie. You've been a super host. So thank you so much, because you've made all the webinar very easy and very straightforward. And thank you to all the people who has been listening so far. I will be pleased to help you in your fertility journey. So if you have any questions or you'd like to schedule a consultation, you know that it's free first consultation, and it can be done through WhatsApp, through Skype, and we will try to accommodate you as soon as possible. So thank you for listening so far. Thanks.
Yes, and we have one more question, so I think that we will have it now. And what is the result of the match?
I don't know what's the result of the match. I haven't even had time to check my phone or anything, so I don't know. We will hopefully, I think that the match is not finished yet, but we will hopefully find out soon.
But everybody knows which is the proper result today, right? You are from Barcelona, so there is no other option.
We'll see.
Yes. So, okay, we don't have any more questions, so we will be slowly finishing, so Dr. Maria can watch the end of the match. And then thank you all for your participation, and thank you, Dr. Maria, for all the knowledge you gave us today. Remember that you can find the rewatch on our website and on YouTube, and share it with anybody who should have those information from Dr. Maria from Fertty International. And Dr. Maria, do you have any final words which you want to say to us, please?
Yeah, my final words are only thank you. Thank you all thank you, Sophie, for making everything so easy. And thank you to all the audience for being here and listening to us. And so you have the doors of Fertty are open for everyone who wants to come. And as I said, through WhatsApp, through Skype, through Viber, the way that it suits you better.
Have a great evening and night and day wherever you are today. See you next time. Thank you again, Dr. Maria and Fertty International. It was a pleasure. And we are saying bye-bye for today. Until the next time.
Bye.
Bye.